médicos que están de Guatemala, El Salvador, Ecuador y también de el Perú. Así que, pues, como ustedes saben, estamos en un ciclo de conferencias continuas, preparando a los médicos, dándoles actualizaciones y sobre todo lo que queremos es que nuestro mensaje sea claro y preciso. Bienvenidos todos. Thank you, Alessandro, for being with us. Most of the people already know who you are, and
Yes.
we are ready to start. And thank you very much for one more time for your time and for giving us some knowledge on all your experiences and all the background that you have.
Okay. Thank you very much, Raul. Thank you, everybody, to be here for this webinar. Good night from Italy, because it's already night here in Europe. But for you, I think, good afternoon. Thank you, because I'm always very pleased to speak for my friends in South America, and this is an occasion to speak with you. Unfortunately, through a computer and not in person, but I hope that very soon we will have again the possibility to share some time in the same room all together. Today, we will have 2 hours webinar about low-dose pharmacology for immune-related disorders. And I hope I will have all the time to introduce you for the use of our medications in the case of inflammatory, autoimmune, and allergic diseases. This webinar will be mainly based on pharmacology, but you will see we will speak also of application by clinical point of view. Low-dose pharmacology, because low-dose pharmacology is a perfect expression by a therapeutical point of view for systems medicine, which is, as you know, a new trend in medicine, very well recognized all over the world. And low-dose pharmacology found a sort of house under the umbrella of systems medicine for many reasons you will see with me tonight. It's nice to speak introducing this webinar about system medicine because, you know, we are seeing a sort of translation from a typical reductionistic view of the human body, every single organ, not the complex, through to a new vision, which is a complex vision of the human body. And we need, and we have to thank psychoneuroendocrine immunology in the 80s, when, with Robert Adler, for the first time, we started thinking in terms of mind and body, and not only by a philosophical point of view. But in the last 2 decades, a new trend, system medicine, popped up in the field of medicine. According to system medicine, the human body can be considered as a network of communicating cells. You can see in this slide, on the right side of the slide, the typical representation of the human body according to system medicine. Those cycles you see are named nodes, but even more important than nodes are the little lines which are so important to express the concept of the complexity of the human body. So all the systems, all the organs are connected to each other. But if we go from the big to the small, we see also that all the cells are connected to each other. According to a paper published on Annals of Human Biology in 2013, now we know exactly which is the number of cells in the human body. It's a big number, 40,000 billion cells. Please think and visualize in your mind this big network where all the cells talk to each other. In molecular biology, we are used to speak, in fact, in terms of bidirectional crosstalk between cells. Just to give you an idea, this is a very recent paper from Nature, May 2024. They mapped a 1 cubic millimeter of the brain. It's not so outstanding, the number of neurons, 57,000 neurons, but it's really amazing the number of synapses, 150 million synapses. What does it mean? That are more important the connection between cells than cells by themselves. In order to understand what does it mean, crosstalk between cells, and to understand how signaling molecules, which are the base of our pharmacology, are so deeply involved in the crosstalk, look at this paper from Letter of Nature 2016. You can see, please just look the right side of the slide, the connection between interferon gamma and the neurosystem. In fact, we are used to think of all the different types of interferons as molecules involved mainly in the immune system. Yes, it's true, but not only. In this paper, you can see, please look at the red lines, how interferon gamma is involved in social behavior. I mean, if we have a good expression of interferon gamma, we are willing to stay with other people. If we don't have a good expression of gamma interferon, we tend to the isolation. So it would be interesting to dose, for instance, interferon gamma in children with autistic spectrum disorders. It's interesting to see the totipotential of signaling molecules in the complex crosstalk in all the human body. So why low-dose pharmacology is the perfect therapeutic application for system medicine, which is the new paradigm in medicine? Because our pharmacology is based on signaling molecules. When I speak in terms of signaling molecules, I mean cytokines, interleukins, and interferons, the words used mainly by the immune cells. Neurotransmitters, the words used by the central nervous system and peripheral system. Hormones, the word used by the endocrine systems. And growth factors, the molecules used by the cells to nurse each other. So it's really amazing and very modern, the idea to use as active principles medications based on these molecules. This is exactly what we do in what we prepare in our laboratories in Milan. If you have the concept of human body as a complex system, and you are already visualizing in your minds the crosstalk between systems, organs, cells, I would like to introduce another concept to understand the deep meaning of system medicine. The concept of crosstalk along axes, along organs, along systems. I will give you some example, some axes of particular interest. One, a virtuous axis. Another one will be a vicious axis. Let's start from the virtuous axis, brain muscle. It's interesting to see, please look at the green arrow, bidirectional green arrow. The connection between brain and muscle is due to a neurotrophin, BDNF, brain-derived neurotrophic factor. That for us, it's a medication, and you are going to see all the possible clinical uses of BDNF. It's so interesting this, because already the old Latins said, mens sana in corpore sano, healthy mind in healthy body. Recently, some researchers discovered that patients with dementia, included Alzheimer's, who undergo physical exercise improve their cognitive impairment. Why? In the first time, they thought that making some physical exercise, they had a better orientation in the space. Now we know which is the reason why. When we contract a skeletal muscle, we produce brain-derived neurotrophic factor together with many other myokines, for instance, also irisin. It's interesting to see that BDNF, which is maybe the most important neurotrophic factors we have, can be downregulated by some conditions such as anxiety, depression, of the worst kind of stress, acute intermittent stress. But on the contrary, light exposure and physical exercise stimulate the synthesis of BDNF. In this slide, you can see which are the pathways which conduct to the production and to the effect of a good expression of BDNF in our body. If you contract a skeletal muscle, you directly produce BDNF, or you produce indirectly BDNF through irisin. Irisin, a myokine produced by the muscle, modulates the STAT3 signaling. STAT3 is a sort of transducer of the message brought by a growth factor or a cytokine in protein synthesis. The signaling stimulates hippocampus to produce by itself BDNF. And you can see in the upper right side of the slide that good BDNF means neuroplasticity. Good neuroplasticity can mean decreased Alzheimer's disease risk, like in this slide. Interesting, I don't know if you are confident with the concept of blue zones. Blue zones, the title of this slide is What's True, What's New, because something is true, something other is quite fancy. Are some zones in different parts of the planet where we have the highest concentration of centenaries. I'm quite happy because one of these areas is my hometown. I am from Sardinia, the island in the middle of the Mediterranean Sea. Another area is Okinawa in Japan, Nicoya Peninsula in Costa Rica, Loma Linda in California, Icaria between Greece and Turkey. It's interesting because all these parts are so distant to each other and they don't have any contact, also cultural contact to each other. So why these enclaves of centenaries? The idea of the researchers who were involved in the blue zones study is that three are the characteristics of all these areas. First, healthy eating. Second, stress management. Third, physical activity. Once again, we will see why physical activity. Easy to understand that if we eat well, we will live more, for sure. That's the reason why in some parts of our planet where they eat industrial food, they have a lifespan much shorter than, for instance, we Italians. Another way to live longer is to have a good stress management. Interesting is that in all those blue zones, the centenaries pray. It doesn't matter if you believe or not in God, but for sure, praying is a way to meditate. Meditation is very important, and especially a kind of meditation, which is the mindfulness meditation. Very important studies show that mindfulness meditation is able to increase the hippocampal volume for 1%. 1% is something huge because a good hippocampal volume correlates to low level of anxiety and depression. So meditation. The third characteristic of all the blue zones is the intense physical activity. In this slide, you can see that thanks to physical activity, sirtuins go up. We can observe endocrine effect. We have a stronger stress resilience. We are more able to repair DNA. We can take under control oxidative stress, and maybe the most important, we can take under control inflammation. But if you have seen the previous slides, when we have physical activity, we produce a big quantity of the most important neurotrophin, which is BDNF. So we need to understand and know this important neurotrophin, which is for us and for you, I hope, a beautiful, important medication for the good of your patient. First of all, I think that it would be nice if you can turn off your microphones, because I'm speaking, but I am listening someone speaking. So please. Okay, thank you very much. First of all, BDNF, brain-derived neurotrophic factor, it's not just a neurotrophin. We need to be confident with it in order to understand when to use it. And you are going to see a lot of possibilities for the clinical use of this medication. First of all, where it is present and where it is synthesized. In the brain, in the cerebral cortex, especially prefrontal, in the cerebellum.
¿Quieres un camaroncito?
Okay, can you turn off the microphone, please? Thank you.
Por favor, excuse me, Alessandro. Por favor, Natur 2024, apague su micrófono. Gracias.
Thank you. In the basal ganglia, in the hippocampus, as I already told you, it's also interesting to see that BDNF is present and very often synthesized outside of the brain in many tissues and organs. We already have seen that the biggest producer is the skeletal muscle. And it's interesting to see what BDNF is able to do. For instance, at the cerebral cortex, prefrontal cortex, it is involved in high-level thinking, superior thinking. In cerebellum, posture. In basal ganglia, control of involuntary extrapyramidal movements. In hippocampus, control of emotions. Prefrontal cerebral cortex and hippocampus, BDNF is important for learning. So you see what it does, how much important can be to use BDNF in those patients with symptoms related to a deficiency of BDNF. BDNF is a very complex molecule. Normally, we use the mature domain of BDNF, which is neither a big nor a small molecule, more or less 27 kilodaltons. It's interesting to see in this slide that look a little complicated, but please follow me, you will understand deeply what BDNF is able to do. When BDNF links is a high affinity receptor, TRKB, tropomyosin KB, different signaling pathways start. Left side of the slide, BDNF is able to down-regulate NF-KB, which is a trans-nuclear factor, able to activate some pro-inflammatory pathways mediated by interleukin-1 beta.
Ya ves que estamos haciendo algo. En que usted no cree.
Bien, yo creo que
En que usted no cree.
Sugestiones, apóyenme, ya tengo todo el material con mi
There is a
camiseta.
problem with
ya
the
le dije a
microphones.
Darwin.
I
Sí,
asked the
porque-
organizators to
No, de
intervene.
arena, compramos también arena. Allá trajeron la arena.
Cuídeme a usted.
Downregulating NF-κB, left side of the slide, BDNF is able to control some of the most important mediators of the inflammation, interleukin-1 beta, interleukin-6, TNF-alpha. So not only a neurotrophin, but a powerful controller of neuroinflammation. Through the GSK3 beta pathway, BDNF is able to stop the phosphorylation of tau protein in tau P protein. If we have a good expression of tau protein, we have stabilized microtubules in the brain. But the phosphorylation creates some tangles of tau protein. Tangles of tau protein works as well as beta amyloid. So they interfere with signaling between neurons. BDNF is able to stimulate the production of interleukin-10. We will see how much important is interleukin-10 in controlling inflammatory processes. And it has a very powerful antioxidant activity through the stimulation of superoxidodismutase and glutathione peroxidase. This is what BDNF do by a molecular biology point of view when it binds its high affinity receptor. But there is another kind of receptor specific for BDNF. It is P75, and you can find it on endothelial cells, cardiomyocytes. And it is important in order to control heart activity and also vessels activity. So you can see how big is the range of action mechanisms due to BDNF. So, which can be BDNF action on central nervous system? BDNF is involved in neuronal survival, neuronal growth and differentiation, synaptogenesis, synaptic transmissions, in other terms, synaptic plasticity, and neural plasticity. More recently, they discovered that some pluripotent neuronal stem cells of the brain are full of receptors for BDNF. So, very possibly, using BDNF, we can wake up this pluripotent stem cell. Possible application after a stroke, for instance. So another reason why to consider BDNF by a clinical point of view. BDNF is very deeply involved in cognitive functions and brain aging, especially memory, learning, and high-level thinking. I mean, after 50 years of life, would be mandatory to take a GUNA BDNF in order to preserve these cognitive functions and to counteract brain aging. Interesting is also the role played by BDNF for stress and depression. We know very well that hippocampus atrophy is correlated with chronic depression. And we also know that stress and hypercortisolemia reduce the expression of BDNF. We have seen already in the previous slide. And if the exposure is persistent, these kinds of conditions can lead to hippocampus atrophy. But hippocampus atrophy means chronic depression. So very possibly BDNF is involved also in controlling some depressive symptomatology. And this is true because if you look at the literature, you can see a sort of liaison dangereuse, as the French say. In fact, BDNF is considered a sort of key transducer of antidepressant effects. On the same way, some antidepressant medication, such as SSRI, improve BDNF activity. So it's interesting, the possibility to be considered to use GUNA-BDNF in overlapping with SSRI for the treatment of depression, maybe also major depressive disorders. This is absolutely true and very well demonstrated also in some preclinical studies. The infusion of BDNF increased 5-hydroxytryptamine and decreased the urine catabolite of serotonin. So for sure, BDNF improve the activity of serotonin. That's the reason why we consider it as a medication in overlapping with SSRI for the treatment of different kinds of depression. It's interesting also to take a look at the correlation between stress, inflammation, and depression. This is another apparently complicated slide, but it's very interesting because it shows the possible link between chronic depression and dementia. Under stress, please look at my pointer. Under stress, we activate the HP axis, hypothalamus, pituitary gland, adrenal axis, which leads to hypercortisolemia. You can see in the left side of the slide. Hypercortisolemia can lead to a downregulation of neurotrophic factors with a difficulty in neuronal repair that can lead also to apoptosis. This is something we know very well. What is much more interesting is what happens in the right side of this slide. HPA activation leads to a condition of low-grade chronic inflammation. And we know which is the main actor of this kind of inflammation that we will study a lot later on. It is interleukin-6. Interleukin-6 overexpress activate two kinds of enzymes, named 2,3-indolamine deoxygenases and tryptophan deoxygenases. Why they are so important? Because they are able to shift the good pathway tryptophan, 5-hydroxytryptophan, serotonin to the bad pathway of kynurenine. Kynurenine is a molecule with a high affinity for serotonin receptors. So if you follow this pathway, kynurenine will occupy serotonin-specific receptors, and when the real serotonin will arrive, they will be occupied. But unfortunately, kynurenine also has a strong neurotoxic activity, and it is involved in hippocampal atrophy. That's the reason why of depression, and for sure in memory and cognitive decline. That can lead to some forms of dementia. About kynurenine, we have a lot of studies that you can find very easily in PubMed, for instance. This is from Frontiers in Neuroscience. It is so true that depression is an inflammatory disease that in 2016, Neurobiology of Stress published this interesting paper. Take a look to the title, Integrating Interleukin-6 into Depression Diagnosis and Treatment. Interleukin-6 is the main interpreter of chronic inflammation. So we know now that even depression is an inflammatory disease. And when we speak about inflammation related to depression, we are speaking in terms of neuroinflammation. In this beautiful slide, you can see all the directions that a neuroinflammation can take towards anxiety and depression, foggy brain. You have seen in many of your patients with long COVID, chronic fatigue syndrome, cognitive and memory disorders, impairment of cardiovascular symptoms. So if we can take under control neuroinflammation, many disorders will be taken under control. So this is the first possible protocol that I propose to your critical opinion. In case of depression, I don't want to say always major depressive disorders. In those cases, for sure, in overlapping with other medications such as SSRI, this combination, GUNA-BDNF, in order to take under control hippocampus activity, GUNA-serotonin in order to make more sensitive specific serotonin receptors, and GUNA interleukin-10 in order to take under control the neuroinflammation can be an interesting association in terms of systems medicine. Normally, directions and administration ways are 20 drops twice a day for each medication for at least 2 months. In these slides, it's also written children under 6 years, but is more because we need to write that by a regulatory point of view, but I hope kids will be not under major depressive disorders. So this is a very effective possible association, but it's nice to arrive to a possible therapeutic protocol starting from the neurobiology in this case. This is the field where we suggest the use of this association. Mild depressive disorders, you can also think just to that association of 3 low-dose medications. For major depressive disorder, for sure, in association with, for instance, SSRI. The concept of overlapping, it's very familiar for us and in general in integrative medicine. When we speak about BDNF, also according to Italian and international real-world clinical experience, many are other pathological correlations. For sure, in some forms of dementia, some forms of obsessive-compulsive disorder. Interesting is also the use of BDNF for psychogenic eating disorders, such as anorexia and bulimia. Please look, my friends, that I always speak in terms of overlapping therapy. In this case, for instance, patients diagnosed with anorexia and bulimia show lower serum BDNF concentration in comparison to healthy people. Big experience in autistic spectrum disorders and ADHD. And also always for all the pediatricians who are connected, specific learning disorders, dyslexia, dysgraphy, and all the other kind of specific learning disorders. And now we are performing a clinical trial about the use of BDNF for sleep disorders, especially phase 3 sleep disorders. And the preliminary data are really outstanding using BDNF in sleep disorders. So you can see how big is the possible range of activity of our medication. I am quite confident speaking about this medication because we have strong evidence. This is the study published on Brain Sciences in 2020, University of Novara, Northern Italy, the role of BDNF on aging modulation markers. First of all, we observed that the effect of red arrow low dose BDNF in comparison with black arrow high experimental dose of BDNF, picograms versus nanograms, is much more effective. For instance, interesting, we found more BDNF in the brain of the mice treated with picograms than in the brain of mice treated with nanograms. Maybe because low doses pass easy through the blood-brain barrier. But as the researchers wrote in the conclusion of the study, very possibly because low-dose BDNF stimulate the endogenous production of BDNF, and very possibly at the hippocampal level. It is able to reduce reactive oxygen species expression, and you know how much important is oxidative stress in the etiopathogenesis of some forms of dementia. It increases the cell viability both for cortical neurons and astrocytes. Always remember red arrows, GUNA BDNF, black arrow, allopathic experimental drug. It is able to stimulate the astrocyte proliferation, and you know very well that astrocytes are the only brain proliferative cells. BDNF low dose increase ApoE2, apolipoprotein E2, which plays a protective role against dementia. Differently is and works ApoE4, but also BDNF low dose increases SIRT1. So in this study, really, we can appreciate the big potential of this molecule. Not only for depression, in general, the directions are 20 drops twice a day for at least 4 to 6 months for autistic spectrum disorders, as well as dementia. In children, since it is very effective in the pediatric age for all those disorders we already have described, we suggest 10 to 20 drops twice a day, but always for a long time. Actually, already after 4 or 5 weeks, you will see the first benefits. Interesting, it's also the possibility in the use of BDNF in the cardiovascular system. Very recently, Minerva Cardiology and Angiology published an interesting pilot study performed by a very important Italian cardiologist from Rome, Professor Massimo Fioranelli, about the effect of GUNA BDNF on atrial fibrillation, to be more precise, paroxysmal atrial fibrillation. This is maybe due to the modulation exerted by BDNF on the calcium channel. So, in other terms, to the cyclicity of contraction and relaxation of the myocardial muscle. In this pilot study, 22 patients with paroxysmal atrial fibrillation, no structural signs of heart disease were present, and not pharmacological treatments were suspended. The primary endpoint was the reduction in minutes for months of paroxysmal atrial fibrillation. In this slide, you can see the result. At T0, the minutes for months were 65.3. After 3 months of treatment, 20 drops twice a day of GUNA BDNF, the minutes per month were 9.5. It is really a great, great result. Interesting, it's also to see that the best results were registered for elderly people. So a big hope also for elderly people to rejuvenate, in other terms, their heart. Interesting is also to see some recent research about some nuclei of neurons in the heart. In fact, we are used to speak about the heart-brain axis nowadays. But since we are a system, we also have to consider an example of vicious axis, gut joints. We are always used to think in terms of gut-brain axis, but there is also a tight correlation between gut and joints, and this correlation is played by pro-inflammatory triggers. This is just a panoramics about all the literature, but this is just a little part, which correlates cartilage, gut, and microbiome in the onset of osteoarthritis, for instance. So it's a very interesting topic. We also know that an overpopulation of Clostridium, Streptococcus, Bacteroides, and Firmicutes are involved in the etiopathogenesis of cartilage. I am in love with this study that show the correlation between the junctional systems between epithelial cells in the mucosa of gut villi and the immune system. On the left side of the slide, you can see the control, and you can see this red line that show a perfect epithelial monolayer. If you look at the immune system, there is a perfect homeostasis between Th1 and Th2, no inflammation. But if you look on the right side of the slide, you see that that mucosa lost its integrity, especially the junctional systems are completely broken. If you look at the immune system, you see that there is an overexpression of Th1 lymphocytes, which are involved in inflammatory processes, and a downregulation of Th2 Treg producing interleukin 10. What is interesting is that we don't know if the damage in the gut mucosa was due to the impairment in the immune system, or the impairment of the immune system is due to the original damage in the gut mucosa due to an alteration in the homeostasis of the microbiome. We need to think in terms of complex system. And if we look at the immunological reflexation, you can see that there are some pro-inflammatory cytokines which are upregulated in the joints because of a dysregulation in the gut microbiome homeostasis. They are TNF-alpha, interleukin-1 beta, interleukin-6. Please look at this study because it is another possible clinical application of our low-dose pharmacology. This is a study published on Gastroenterology Research 10 years ago. It is about oral administration of two powerful anti-inflammatory cytokines, interleukin-10 and anti-interleukin-1, in a model of inflammatory bowel disease. And in this study, we demonstrate that the association of these two low-dose medication ameliorates experimental intestinal inflammation. A lot of data. For synthesis, please look at the part with the red cycle, the expression of TNF-alpha. Column number 1, those are mice, healthy mice. Column number 2, TNF in mice with a model of Crohn's disease, provoked with dextran sodium sulfate, to be precise. Column number 3, TNF-alpha after treatment with conventional anti-inflammatory medications, including also anti-TNF-alpha. Great results, but you know, very severe side effects. Column number 4, TNF-alpha level after treatment with GUNA interleukin-10 plus GUNA anti-interleukin-4 low dose. Column number 5, if you only use the low dose without the treatment pharmacological technique that we use in our laboratories, which is called sequential kinetic activation. In that case, low dose is not effective. Only the medication released on the market is effective in controlling TNF-alpha. This is a possibility also for your patient with inflammatory bowel disease, for instance, to maintain them in remission after treatment with monoclonal antibody. It is a very interesting approach because the clinical safety for long-term treatment with our medication is 100%. And these are some pictures taken with the immunofluorescence of some gut crypt. On the left side, gut crypt affected by Crohn's disease. On the right side, after treatment with our two medications, Guna anti-interleukin 1 and Guna interleukin 10. And you can see that the epithelial monolayer now is completely preserved. Very recently, no more than 1 year ago, we published on Current Medical Chemistry an interesting preclinical study about the effect of, once again, anti-interleukin 1 low dose and interleukin 10 low dose on inflammatory markers in cultures of synoviocytes and chondrocytes. Let's go to see the results. You can see in the green cycle how effective are especially interleukin 10 in downregulating interleukin 1 alpha and 1 beta, which are the two triggers of inflammation, as well as interleukin 6, which is involved especially in chronic inflammatory diseases. Both interleukin 10 low dose and anti-interleukin 1 are effective in controlling the two main pro-inflammatory cytokines involved in osteoarthritis, interleukin 1 and interleukin 6. Another demonstration of the effectiveness is that using these two medications, we block the translocation of NF-κB into the nucleus because we increase the opposing factor of NF-κB, which is IkB alpha. So for sure, we know exactly which are the intimate mechanisms where our medications work on. But maybe you are also interested to clinical applications of our medications for musculoskeletal disorders, especially osteoarthritis. In this case, it is a study performed by Professor Marco Mattucci-Cerinic, which is head of the Department of Rheumatology in Florence University. He tested Guna anti-interleukin 10 plus Guna interleukin 10 in reason of 20 drops twice a day for 24 consecutive weeks in patients with early stage osteoarthritis. To be more precise, the patients were 27 with osteoarthritis with Aberdeen nodes, 14 erosive osteoarthritis, 6 knee osteoarthritis. Among all the data, I'm glad to show you the VAS value at T0 baseline after 3 months and after 6 months. You can see a dramatic reduction of the VAS for pain, but the same data also VAS for general health and the Dreiser test. But the pain is always something very impressive that we can observe directly after the use of these medications. To be very pragmatic, this is the protocol that we suggest: Guna interleukin 10 plus Guna anti-interleukin-1, always 20 drops twice a day for the same of the study, 4 to 6 months. I think that you manage many patients with osteoarthritis. This protocol can be really a very interesting possibility. Just to relax after speaking about inflammatory diseases, I want to come back to the concept of system medicine because it's interesting to see this new point of view in medicine, because we are used to study the etiologic causes of many diseases, such as traumas or bacteria or viruses, but also bad emotions, negative emotions can be etiologic cause of severe systemic disease. This is very well expressed in system medicine by the concept of interactome. Interactome means a network a social network. In other terms, even emotions can be triggers of inflammation, negative emotions. In other terms, emotions are molecules, in Latin, sine materia, without the possibility to touch them, but they can affect your body, inflaming the body as well as a virus. This is a beautiful study that always I show to the attendees of some seminars or webinars. This is a study published on brain behavior and immunity in 2013. Professor Miyamoto and colleagues. They correlate the values of interleukin-6 that you already have understood is the marker of chronic inflammation with increasing negative emotion in two clusters of subjects, American and Japanese, able to meditate. We come back to the beginning of the seminar, meditation. You can see that in the American people, negative emotion provoke dramatic inflammations. Instead, because of mindfulness meditation, Japanese people are able to counteract the overexpression of interleukin-6. If you ask me why, very possibly, I think because mindfulness meditation increases the expression of interleukin-10, which is the opposing cytokine with anti-inflammatory activity of interleukin-6. But we cannot not to consider in modern medicine also the social network where the patient is embedded. And we have to take under account that. This is another beautiful study, especially for pediatricians, published in 2022 on adversity and resilience science. In a synthesis, the study says that early life adversity, such as abuse, maltreatment, neglect, provoke inflammation in the body of the kid, and when the kid will be an adult, this is a transverse longitudinal study, when the kid will be an adult, that adult will have highest level of inflammatory markers, such as interleukin-6, CRP levels. So how much important is to take care and love kids during childhood, because they will be adults with reduced cardiovascular risk, but in general, reduced inflammatory risk. This is another interesting paper about the interactome, published on PLOS ONE and then published also on the Italian Journal of Pediatrics. In this study, the researchers showed that 50% of mothers during breastfeed don't look at their kid eyes. This is not nice, you can say, yes, but it is dangerous by clinical point of view, because those kids without eye-to-eye contact with their mother have a reduced neurodevelopment. How much important is also what we established, just look to each other, and especially when our children are so young. We are preparing a generation of unhappy kids. Also, these kind of devices, such as cell phone, are involved on that. In this study, published on PLOS ONE, they say that over 4 hours in front of a device relate with stress perception, use of pharmacological substance, and what scared me, suicide ideation. We need, according to system medicine, to consider also these triggers. These triggers, they are important as well. But since I don't want to be a negative trigger speaking about sad conditions, this is a nice paper, and I think that I will provoke a smile on you, because published on Psychoneuroendocrinology in 2006, they show that during romantic love, a growth factor, NGF, which is involved in neuroplasticity, increases. That's beautiful. When we are in love, our neuroplasticity is better. Unfortunately, NGF plasma levels goes up only in the early stage of love. That means that after 2-3 months, it stops to goes up. So the only way to always keep up the level of NGF and keep a good brain plasticity is to be continuously in love. And to be in love, sometimes we need also to change the pattern. I'm joking, it's not politically correct, but just after 1 hour of webinar, to smile all together. If you agree, I think that we can make a 3 minutes break, but really just 3 minutes break, for me also to see some slides. And in 3 minutes, we can go on again. Do you agree with me? 3 minutes, 3 of break.
Thank you, Alessandro. Take your
Okay,
time.
I will be back in 3 minutes. Thank you.
Yes, thank you, Alessandro. Perfect.
All right. Hopefully you are still there. So we can go on for the second part of our webinar. And I will take you deeply into low-dose pharmacology and the clinical application of low-dose pharmacology for immune disorders, meaning for that, inflammatory disease, immune impairment, and I hope to have enough time also for allergic diseases. But once we will have understood some mechanisms related to the immune system and the use of signaling molecules for that, you will be able to go on by yourself. Low-dose pharmacology is a paradigm shift in pharmacology as well as system medicine. Is a paradigm shift in medicine. What is beautiful is that Guna has been the first one thinking in terms of low-dose pharmacology more than 20 years ago. But now in the world, not only us are involved in low-dose pharmacology. Now is a world trend. Just to give you an idea how updated you will be using low-dose pharmacology in your clinical practice. Some, there are thousands of publications about low-dose pharmacology all around the world. For instance, Canadian Medical Association Journal, look at the title, Is Bigger Better? An argument for very low starting doses. This is from Australia. Low drug doses may improve outcome in chronic disease. The Journal of Immunology, low-dose interleukin-2 therapy in transplantation. British Medical Journal, rapid induction of clinical remission by low-dose interleukin-2, a beautiful interleukin with a big potential by clinical point of view, in patients with refractory erythematosus systemic lupus. So really, for us, it's really a pride to see that the way we open now is used by many other researchers and clinicians. By our side, for those of you who don't know Guna, we invest a lot of energy in preclinical and clinical research, and these are just some of many publications only indexed and impact journal that we have. So it's a big commitment, and we keep on invest our energy in research. Never we will stop on that. Our pharmacology, you already have seen that, is based on signaling molecules. I am totally in love with signaling molecules. They are beautiful glycoproteins, the most part of them, and they are just to understand their deep role, they are involved in bioregulation of the physiology. If in this moment I'm thinking I'm moving, is because of signaling molecules. And it is interesting that an up or down regulation respecting on the homeostatic concentration of the signaling molecules can be the onset of many diseases, especially inflammatory, autoimmune, allergic diseases. But we have seen also dementia, depression, and so on. So really, this is the future for me, already the present of the modern pharmacology. For those of you who are not confident with the concept of signaling molecules, just look at them as a sort of messengers, the words used by the cell to talk to each other and to lead this way the body physiology. This is a beautiful way to imagine the cells. Try to anthropomorphize the cells. They talk to each other, not obviously as we humans. Their dictionary is the dictionary of signaling molecules. Another characteristic of the cells is that cells talk, but more than talk, they whisper to each other. at a very low volume. If you change the concept of volume in the concept of concentration, the concentration of signaling molecules used by the cell to talk to each other is a sub-nanomolar concentration, a very low dose concentration. That's the reason why our pharmacology is called low dose pharmacology, if you want to prepare medication with these molecules. It's interesting as a basic information to know that in our body, in healthy conditions, meaning for that in homeostasis, the physiological concentration of signaling molecules is between picograms, femtograms. You can see in this slide that an hyperconcentration as well as an hypoconcentration correlates with a pathological condition. So our therapeutic goal will be to reconduct an hyperconcentration and an hypoconcentration in the homeostatic level. We can do that, and we are going to learn how to do that. This is a concept that you need absolutely to have as yours. This is a paper from my Bible, which is a journal named Cytokine. In 2014, Cytokine published this beautiful article, Neither Good Nor Bad in Nature. These molecules, for instance, cytokines, can be good or bad. It depends by the concentration. With the physiological low dose concentration, they exert a protective role. But if they are up or down expressed, they play a pathogenic role. So also by a pharmacological point of view, you must be very precise preparing these kind of medications. We know how they work. For instance, a low physiological dose upregulates transmembrane receptors. Transmembrane receptors are a sort of ears of the cells. So we make cells more sensitive to the messages. More recently, we published a paper on International Journal of Molecular Sciences about the action mechanism not exerted on transmembrane receptors, but into the cytoplasm in order to make the cell more active. To be precise, for those of you who are involved in molecular biology, we have seen that in cultures of Jurkat cells, low-dose interference is able to block SOX1, suppressor of cytokine signaling 1, which is a sort of button able to switch off the signaling pathway induced by the binding between the signaling molecule and the transmembrane receptors. It's evident that if you block the button which turns off the signal will remain more active into the cell, and the cell will be more active. This is the way we are able to increase a cellular response using our medications. But this is something that maybe will be interesting for molecular biologists, less for clinicians as you, but it's important to see, at least in the surface, the mechanism of our medication. So it's not only important the right message, but also the right volume, picograms per milliliter, and the delivery system too. That's the reason why, speaking about drug delivery system, that we speak in terms of sequential kinetic activation, which is the preparation mode that we use, and it is patent, in our laboratories. Only if you prepare a low dose according to this pharmaceutical technique, they will be effective medications. Another aspect that I want to share with you is this. If cells talk to each other and the dictionary is due to the signaling molecules, another question that for me is very interesting: where do cells speak? We have a human internet, and we also have the speed fibers, for instance, nanotubules of fibrin, where molecules, signaling molecules, go even faster. The human internet, where all the cells talk to each other, is that beautiful tissue, which is the extracellular matrix. I hope that you can see this video from nature. This is amazing because you are seeing the extracellular matrix, the nanotubules of fibrin, and please look that now you will see a signaling molecules passing from one cell to another one. Do you see this little white spot? That can be serotonin going to a target cell, or beta estradiol going to a target cell. In other terms, my friends, it's absolutely true that cells talk to each other. Now we know which are the words, and with our medication, we can restore the right chat in the social network, which is our body, with 40,000 billion cells. But we need to preserve the integrity of the extracellular matrix, which is this one in light blue, because all the signaling molecules pass through the extracellular matrix with the goal to arrive to the target of the transmembrane receptors. It happens if the extracellular matrix is plastic, but if it is rigid because of pollution of the extracellular matrix, signaling molecules will be not able to pass through the ECM, and the cell will be not provided by the right message for the right biological function. The plasticity of ECM, I'm sorry, but I need to stress this concept, is essential for the maintenance of all biological functions. Look that also the most updated scientific literature is saying that stiffness condition of ECM correlates with abnormal angiogenesis, strange proliferations, metastasis, genome instability, immune suppression, and resistance to therapeutics. I just want to underline resistance to therapeutics, because with one of our medication, you will be able to boost all the therapies. With synthetic drugs, with homeopathic drugs, with phytotherapeutic drugs, with acupuncture therapies. Look at this slide with animation. On the left side, this is just an educational slide, obviously, you can observe a plastic ECM with a good expression of type 1 collagen. And you can see some receptor, specific receptor, GABA receptor for benzodiazepines. Since the ECM is plastic, you can see that the most part of benzodiazepine molecules arrive to the GABA receptor. But right side of the slide, if you see a rigid fibrotic ECM, why? Because of a toxic condition, you alterate the ratio between type 1 collagen and type 3 collagen. Now the DCM is rigid, and look, benzodiazepine, this is just an example, molecule arrive with big difficulty to the GABA receptor. That's the reason why sometimes you need to increase the dosage. But if you maintain, if you reestablish the plasticity of ECM, the effect of every drug will be much better. So please never forget, in almost your therapeutic plan, in order to boost all the therapies, this masterpiece of our pharmacology, which is Guna Matrix. Guna Matrix is a medication in drops. It is a multi-component medication where you can see different core of action: toxic neutralization, matrix solubilization, lymphatic drainage, and so on. You can see in this case, because we don't have time to examine all the ingredients, pyrogenium and hyaluronidase. If some of you is an homeopath, maybe he will know pyrogenium, but maybe he will not know that pyrogenium, because of the high quantity of lipopolysaccharides, is able to increase the production of interleukin-1. Interleukin-1 physiologically exerts many functions. For instance, stimulate a microinflammation, which is able to burn toxins in the extracellular matrix. But more recently, we discovered that interleukin-1 is able to increase the activity of metalloproteinases 1 and 3, the hydrolytic enzymes which are devoted to maintain plastic the extracellular matrix. So really, this is a great medication. Please always consider this medication in your therapeutic plans. According to a study performed at the University Tor Vergata in Rome, we measure the increase of metalloproteinases 3, you can see in the red cycle, in the control, in the Guna matrix cell culture. Good. It has a catabolic action, ECM drainage action, just to wrap up what I had told you, anti-degenerative action and lymphatic drainage action. Always we recommend for 2 consecutive months, but even more, 20 drops twice a day, in combination with other medications, or if you want to perform a total body detox therapy, also by itself. Oh, sorry. And now let's go to see also how to use single cytokines to manage inflammation, immune impairment, and allergy. We need to start from this conceptual pillar. Diseases can be considered as an expression, a consequence of an imbalance of T helper subsets, and even more important, a consequence of changed expression of related signaling molecule concentration. What does it mean? In healthy condition, if we take a look at our immune system, we have a good balance between different T helper subsets. Look that T helper lymphocytes are a sort of orchestra directors, where the orchestra is our immune system. Th1 and Th17 from one side, Th2 and Treg from the other side. Th1 are involved in cell-mediated immune response, and they are good, but if overexpressed, they will be responsible of inflammatory processes. In fact, Th1 produce their own typical pattern of cytokines, interleukin-1, interleukin-6, gamma interferon, and so on. Those cytokines have an immunostimulating activity, but only if they are expressed in physiological concentration. Neither good nor bad in nature. Do you remember the paper from Cytokine Journal? Th2 and Treg produce blue cytokines, such as interleukin-4, interleukin-10, and they show immunomodulating activity, but only if they are in physiological concentration. Physiological concentration versus up or down expression. This is a good condition. I hope that in this moment, by an immunological point of view, this is the picture of your immune system. It would mean you are healthy. But if you are attacked by inflammatory triggers, the immune system reacts overexpressing, upregulating the same red cytokines, which lose their virtual activity, immunostimulation, and become pro-inflammatory cytokines. And the most important ones are interleukin-1, 6, TNF-alpha, interleukin-17. We are going to study them. On the other side, in conditions of immune impairment, we have a downregulation of the red immunostimulating cytokines, and unfortunately, an overexpression of immunomodulating cytokines that now, because of their upregulation, become immune suppressive cytokines. This is the typical picture for my friends, pediatricians, that you observe in kids with upper respiratory tract infections. This is typical for that. Okay, this is a bad condition. So if all the diseases are expression of imbalance in the immune system, can we rebalance? In other terms, clinical problem. Is it possible to modulate the action of cytokines and other signaling molecules in order to reconduct their concentration in the homeostatic condition? Yes, it is. We use same cytokines in order to enhance the biological activity of the homolog cytokine. But even more important is the use of antagonistic cytokines, which are used in order to slow down the biological effects of another specific cytokine. We observed that, for instance, in one of our first studies published on pulmonary pharmacology and therapeutics, where using antagonistic cytokines for interleukin-4 and interleukin-5, which are markers of allergy, those cytokines were reconducted in homeostasis, in the right expression. So really, this is what can happen using low-dose pharmacology. The first application is what can we do in inflammatory disease management. Start from the clock of inflammation, because with our medications, we can intervene in different moments of the inflammation process. Just to be very didactic, the timing of inflammation, the clock of inflammation, sees the inflammation onset at T0, inflammation progression for the consequent 48 hours. After 3-4 days, the resolution phase starts, and after 1 week, we observe inflammation resolution, proliferation, and remodeling of the injured tissue. According to T0, T48, T72, T96 hours, we know exactly which are the molecular mediators involved in all those 4 different moments. Interleukin-1 beta is the marker of inflammation onset. Interleukin-6 mainly is the marker of inflammation progression. ACTH and lipoxin, pro-resolving mediator, is the marker of resolution phase onset. And interleukin-10, TGF-beta are the main markers of inflammation resolution, proliferation, and remodeling. Look that all those molecules for us become medications. We also know which are the cellular mediators involved in the different moments of the inflammatory process. They are, for instance, to be synthetic, macrophages M1 in the first moments of the inflammatory process, and macrophages M2 in the second moment of inflammation. This is a perfect process led by Mother Nature. But by a therapeutic point of view, Can we overlap some medications to the different moments of the inflammatory process? Absolutely, we can do that. For instance, we use good anti-interleukin-1 in the first hours of the process, during the onset of the inflammatory process. We use interleukin-10 during the development of the process. We use interleukin-10 and good interleukin-4 to induce the pro-resolution phase and M1 macrophages, M2 macrophages shift. And we use Guna FGF as oral medication, and MD tissue has site-specifically injected therapy to induce the resolution phase. Look, my friends, that if you have in your hands these 1, 2, 3, 4, 5, 6 medication, you will manage perfectly the inflammatory process. So now let's see in depth how to use this medication. Case number 1, what to do in acute inflammation. We need to counteract the spike of the expression of interleukin-1 beta. Interleukin-1 beta is the trigger of inflammation, and it increases dramatically in the first 24, 48 hours. If you like the concept of balance between Th1 and Th2, you can see that in acute inflammatory diseases, Th1 lymphocytes are upregulated and interleukin-1 is overexpressed. This is a big problem because interleukin-1 activates several inflammatory pathways. For instance, COX-2, PGE2, PGD2, and nitric oxide. I mean, it is a sort of boss of inflammatory process. That's the reason why we use NSAIDs, we use corticosteroids, we use salicylates. But in a reductionistic way, all these beautiful anti-inflammatory conventional medications work only on one of the inflammatory pathways. NSAIDs on COX-2, corticosteroids on prostaglandins, salicylates on nitric oxide. It's much smarter to use good anti-interleukin-1 because blocking interleukin-1, you downregulate the expression of all the 3 signaling pathways of the inflammation. That's really amazing. Interleukin-1 upregulated by a clinical point of view means fever and pain. So you can think of good anti-interleukin-1 as a sort of acetaminophen, for instance. And we can counteract, according to the concept of cross-regulation, interleukin-1 with a monoclonal low-dose antibody, which is anti-interleukin-1. It is a medication in drops, oral drops, and we suggest the use of 20 drops twice a day. But in acute, meaning for the first 2-3 days from the onset of the inflammation, 10 drops every 30 minutes for a couple of hours, 2-3 hours, until acute symptomatology disappears. Using with these directions good anti-interleukin-1, really you will have a strong effect, not only on fever, but also on pain, as well demonstrated in this study about the use of good anti-interleukin-1 in association with colchicine 0.5, 1 milligram daily, and allopurinol 300 milligrams for the management of chronic gout. Please look at the results. Interesting. The VAS for pain. You see the red arrow is the moment where the researchers introduce gun-anti-interleukin-1 in overlapping on the already existing therapy with allopurinol and colchicine. Until that moment, not reduction in the pain VAS. After the introduction of gun-anti-interleukin-1, after 3 months and 6 months, the pain almost disappeared. That's the reason why I speak also about the use of gun-anti-interleukin-1 in pain management. Interleukin-1 beta is involved in pain because it upregulates the release of substance P. So we can manage the release of substance P acting on interleukin-1 beta through gun-anti-interleukin-1. Beside gun-anti-interleukin-1, in pain management, we recommend also the association with guna beta endorphin, because this way, as you can see in this slide, you will not only manage the peripheral nervous system pain transmission, but also the central nervous system pain transmission. In fact, beta endorphin downregulate GABA release, increasing dopamine release, and this way making the body able to stand better the pain sensation. So this association is very effective because you will be working both on the peripheral nervous system and central nervous system. In this case, the association with beta endorphin, we'll see beta endorphin use as well as gun-anti-interleukin-1. I'm sorry, this is in Italian. In acute pain, 10 drops every 30 minutes for 2-3 hours. Continue then with 20 drops twice a day until symptoms disappear. In chronic pain, you start with that administration of the acute management, and then for a long time, meaning for that also months, 20 drops twice a day. According to what I have seen, the best results are when you use combined in benign, acute, and chronic pain management, beta endorphin and anti-interleukin-1. The most part of patients, especially elderly people with comorbidities, face chronic inflammatory conditions. So we need to know that. By an immunological point of view, the marker of chronic inflammatory conditions is interleukin-6. Interleukin-6, as you can easily see in this slide, which show the chronobiology for the interventions of different cytokines during all the inflammatory process, should be involved only in the maintenance for no more than 2, 3, 4 days, the inflammatory process. But sometimes interleukin-6 remains upregulated, and that the conditions that we call low-grade chronic inflammation, and that's the worst condition because we don't see clinically that condition. We don't see neither sign nor phenotypic outcomes, but the inflammation is there and is working, and the persistency of low-grade chronic inflammation leads to the damage of the tissue. So really, that's a big problem. And all the systems, organs, tissue can undergo low-grade chronic inflammation. Cardiovascular system, gut, central nervous system, immune system, endocrine system, epithelial tissues, a reproductive system, or musculoskeletal system. I mean, no tissue is immune at that point of view. As the New England Journal of Medicine explained very well in that paper, a focus of low-grade chronic inflammation, it's not a problem of the primary tissue, because from that tissue, we always observe the spreading of interleukin-6. So when you have a patient with osteoarthritis, very possibly the risk for cardiovascular disease will be higher. The risk for neurodegenerative disease will be higher. The risk for osteoporosis will be higher. The risk for sarcopenia and so on will be higher. I mean, this is absolutely something that we need to counteract. The problem is, in conventional pharmacology, no medication has been designed for the treatment of chronic inflammatory diseases. Dramatically, they use drugs designed for acute inflammatory disease chronically, but they are not designed for long-term treatment. And the sequela of side effects is very severe. We have some possibilities. In this slide, please look, just to be aware about that, after 50 years of life, even though you are the healthiest person, interleukin-6 start increasing. I don't want to be dramatic, but if we don't die for something else, we die because of interleukin-6. So if we can extend the lifespan, we can counteract interleukin-6. Unfortunately, we are doing exactly the opposite. We are under stress. We live in polluted areas. We are overweight and obese. That's a problem, because the adipocyte is a sort of mine for interleukin-6, for TNF-alpha, for CRP. So obesity induces inflammation, for sure. We need to take under consideration all of this. So just to be very didactic in this, I can speak in terms of a tragic equation. A toxic condition means an inflamed body, and an inflamed body means an ill patient. All those symptoms, so-called vague and indefinite, which are related to intoxication, such as overweight, skin rashes, itchy skin, irritability, sleepiness, they are signs of inflammation. And that inflammation is due to a toxic condition. And also, toxic condition relates with inflammation conditions, and those inflammation relates to aging. So if we want to be beautiful and young, we need to counteract interleukin-6 and to drain the extracellular matrix. Thankfully, we know now that Mother Nature gave us a big present, interleukin-10. And look at the titles of this paper. Targeting interleukin-10 family cytokines for the treatment of human disease. Biology and therapeutic potential of interleukin-10. We are very proud because we are the only pharmaceutical company producing interleukin-10, and producing interleukin-10 in the only physiological concentration, which is the low concentration of picograms. Interleukin-10, according to the concept of cross-regulation, antagonism between cytokines, is the perfect counteracting cytokines for interleukin-6. Direction and administration ways: Guna interleukin-10, 20 drops twice a day for a long time, even 4 to 6 months consecutively. My suggestion: you can make a great secondary prevention of comorbidities in your adult and elderly patient, just with a combination of Guna interleukin 10 plus Guna matrix, 20 drops twice a day for long time. We publish a lot on interleukin 10, both preclinical studies and clinical researches, clinical trials. And now I show you. But there is also case 3 after acute, chronic for inflammatory diseases, and case 3 is related to autoimmunity-based inflammation. In case of autoimmunity, always we need to take a look to 2 cytokines, TNF-alpha and interleukin 17. Interleukin 17 is the real marker of autoimmunity. It is an interleukin produced by a subset of T helper lymphocytes named T helper 17, discovered in 2007. And the up regulation of Th17 is related to the difficulty of Th2 to take under control Th17 through interleukin 4 for a lack in the production of interleukin 4. That's the reason why always in autoimmunity conditions, in order to counteract the pool of pro-inflammatory cytokines, especially interleukin 7 and TNF-alpha, we use interleukin 4. Also, for interleukin 4, the directions must be 20 drops twice a day, and the treatment must be a long-term treatment. You can easily understand that we cannot re-educate an immune system in a couple of days. We need months consecutively using Guna interleukin 4. So, in order to have a wrap-up picture of what we have seen till now, I want to show you this slide. If you have an overexpression of interleukin 1, which is a marker of acute inflammation, we use Guna anti-interleukin 1. If you have an overexpression of interleukin 6, which is a marker of chronic inflammatory disease, we use interleukin 10. When we have an overexpression of TNF-alpha and interleukin 17, which are markers of autoimmunity, we use anti-interleukin 1, interleukin 10, and to counteract interleukin 17, interleukin 4. If you are not confident with single cytokines, never forget our multi-component medication named Gunaflam, that contains, besides typical homeopathic remedies for inflammation, anti-interleukin 1, interleukin 10, TGF-beta 1. So this is the base of all therapies in order to counteract inflammatory processes that you can boost with the single cytokines. Some studies, in order to see the effectiveness of our medications. First case, rheumatoid arthritis. The results of the clinical trial, that is an open, randomized, active control clinical trial with low-dose cytokines versus DMARDs, both biological and conventional synthetic DMARDs, for the maintaining of remission in patients with rheumatoid arthritis. 2 groups of patients. After remission, group A was treated with cytokines in low dose, group B with methotrexate. The protocol was Guna interleukin 4, you remember, autoimmunity, Guna interleukin 10, and Guna anti-interleukin 1, 20 drops per day for 12 consecutive months. Follow-up at T12. Please look that all the patients were taken in remission using the MARS monoclonal antibody. Then the patients were divided into groups. One group treated with that protocol, one group treated with methotrexate in order to keep low the disease activity. The results were amazing. Not inferiority in the two groups. But if you look at the group treated with low-dose cytokines, they kept the remission for the 66% of the patients versus 42% for the group treated with methotrexate. We cannot say that our treatment is more effective of methotrexate because, as you can see, the standard deviation is quite big because the little group of patients. Interesting also some other data, such as the pain visual analog scale, not inferiority, global health assessment, and for me very important are laboratory data, erythrocyte sedimentation rate, PCR, not inferiority, but we are speaking about low dose medication, 100% of clinical safety and methotrexate. This is the protocol we used in this experimental study. GUNA anti-interleukin 1, 20 drops once a day for 12 consecutive months, as well as GUNA interleukin 10 and GUNA interleukin 4, all together. This is a big hope for patients with rheumatoid arthritis. Big experience also in some skin disorders. In this case, vitiligo, where you know very well we don't have so many solutions. By an immunological point of view, vitiligo is due to an overexpression of Th1 and Th17 and their related cytokines pattern, and downregulation of Th2 and related cytokine patterns. We perform both preclinical and clinical researches. In this case, an ex vivo study, co-culture of keratinocytes and melanocytes. But even more important, the clinical trial performed in 5 different countries to observe patients. All of them included not had to have more than 15% of total body skin surface involved. That is the cutoff for the use of microphototherapy, narrowband UVB 311 nanometers, which is considered the gold standard till now for vitiligo. Endpoints: reduction of the pigmented area and reduction, hopefully block, of the lesion spreading. These are the results. They repigmented in a percentage varying between 74 and 90%, which is huge. And 100% of the patient block the spreading of the lesion. The protocol is built on the etiopathogenetic cascade of the disease. First of all, since in vitiligo there is a block in the crosstalk between keratinocyte and melanocytes, because no more basic fibroblast growth factor, we provided GUNA FGF. But we needed also to block the pro-inflammatory storm that, because of the autoimmunity these patients continuously live. And you already learned that in case of autoimmunity-based inflammatory disorders, we need to refer to the protocol GUNA anti-interleukin 1 plus GUNA interleukin 4 plus GUNA interleukin 10. So we block the inflammation and we restore the message for the melanocytes in order to produce again melanin. if you want to have once again a glance about the protocol, you see the association, GUNA FGF, GUNA anti-interleukin 1, GUNA interleukin 4, GUNA interleukin 10, 20 drops each a day for 3 to 9 months. The clinical trial was performed 9 months, but we see that the very good results already after 3 months. Look that you can suggest the patient to put the daily amount of drops in a little bottle of water to drink during the day in order to increase the compliance of the patient to the therapy. And this is what I told you, represented by an image. This is a very good way to administer our medications. Some pictures which speak much better than words. This is courtesy from Professor Kadurina, University of Sofia in Bulgaria. You can see left side, T0. This is one of the worst kind of vitiligo, dorsal and transversal. After 6 months of therapy, please look at the results. The reduction is quite impressive. This is another case with the total restitutio ad integrum of the tissue. And I like very much this picture because you can see the biological activity of our medication that starts the repigmentation, normally perifollicular. And this is the picture of the biological activity of our medication. They are able to restore the biology of the cells. So quite impressive. Another good experience in psoriasis vulgaris. Also in this case, more or less by an immunological point of view, we have the same picture of vitiligo. In this case, we also observe an upregulation of Th22. And we perform good studies, both preclinical, for culture of primary lesional fibroblast obtained from psoriatic patients. And for you as clinicians, even more important, the clinical trial with the association, you can take a note, interleukin 4, interleukin 10, and interleukin 11. It was a multi-center, double-blind, randomized, placebo-controlled clinical trial with alternation. The patient took the verum, then washout, and then placebo. Another group started from the placebo, washout, and cytokines. That was quite important for us to understand if the results were related to a placebo effect. Not at all, obviously. And the patients took the medication for 3 consecutive months, always with the direction of 20 drops twice a day. The results. The primary endpoint was the evaluation of PASI, psoriatic area severity index, with an improvement of 55%. It means that the lesion was reduced for 55%. Interesting is also the data related to dermatology life quality index, with an improvement 56% from T0 after 3 months. And this is once again for your utility, the protocol, interleukin 11, interleukin 4, interleukin 10, 20 drops twice a day, each medication for 3 months. Also in this case, you can suggest the way of administration through the bottle of water. Some pictures from University of Sofia in Bulgaria, before and after 3 months. Another case, before and after 3 months. So you can observe that really the improvement is absolutely objective. Another experience, even though not supported by a controlled trial, but these are experience from the real world. But it's interesting, the model of fibromyalgia, because for sure it is a typical condition related to low-grade chronic inflammation. In fact, in this patient, interleukin-6 is very often dramatically overexpressed, and it is responsible of the typical cohort of symptoms: pain, fatigue, depression, sleep disorders. Okay, we know also which are some brain area affected by this kind of inflammation. This is a beautiful study with the functional MRI, and it's interesting to see that these patients that were considered hysteric are not hysteric, they are just inflamed. And we know, because of the image with the fMRI, but also because if you exert a pressure of 2.5 kilograms per square centimeter in a fibromyalgic patient, he will feel pain. Instead, on me, who are not fibromyalgic, to provoke pain in trigger points, you need to exert a pressure which is almost the double of the fibromyalgic patient. This is a beautiful study from the University of Turin. So, since fibromyalgia, no doubt, is an inflammatory condition where interleukin-1 and interleukin-6 are involved, we need to think of GUN anti-interleukin-1 and GUN interleukin-10 to counteract the inflammatory cytokine involvement. We need to act on the release of P substance, you remember, which is involved in the transmission of pain, and gunabeta endorphin is quite interesting. We need also to consider that stress conditions lead to a low release of BDNF. BDNF, we started our webinar, is involved in neuronal survival, neuronal plasticity, and these patients can also enter in the tunnel of cognitive impairment. And you know that is a vicious cycle. So in order to recover a good neuronal plasticity, neuronal survival, GUNA-BDNF can be a good solution. What you can do in your patients in terms of systemic oral therapy is this association of medication, quite complex, but they are complex patients. GUNA interleukin-10 plus GUNA interleukin-10 plus GUNA matrix, everything is played at the level of ECM, GUNA beta endorphin for pain management, and GUNA BDNF for neuronal plasticity. What many clinicians from the field refer is that you change really these patients. So they will be also very good responders to other kind of therapies. Now, I have to tell you, I look at my watch and it is already midnight and 10 minutes. I prepare also the other side of the immunitary sky, which is what can we do in order to support the immune system in condition of immunodepression. But we can do something and we can take a decision together. I think that we did a great job going in depth in some mechanisms of the immune system. If you agree, I am totally available for another webinar where we will see in the same way what it concerns the immune strengthening therapy and the management of allergies. I stop my sharing, and first I need to know if you agree that we can plan another webinar for another part of low-dose pharmacology for immune disorders. But also, I am available in this moment to discuss with you any topic we have seen and to answer possible questions. Okay, someone is there? Raul, you have your microphone off. You have to open your microphone, Raul. I don't hear anyone.
I have a question.
Okay, good.
Whenever you give those treatment for rheumatoid arthritis, do you first give bowel, alveolar, or it's just the anti-1L1 treatment with the interleukin-10?
Yeah.
Or just we give diet with this?
Okay. In the trial, the patient just took GUN anti-interleukin-1 plus GUN interleukin-4 plus GUN interleukin-10, and look that those patients were in remission after a previous treatment with the MARS.
Okay.
Okay. For sure, if you combine the immunomodulation typical of autoimmune diseases, interleukin-4, interleukin-10, anti-interleukin-1, with a good drainage of the extracellular matrix, and taking control of the controller of all the body, which is the gut, very possibly you will have even better results. But you know, when you perform a clinical trial, you must be quite rigid. That's the reason why the results are related only on the use of those three medications, which is quite huge. Yes. Also because it's the only long-term treatment without side effects you can perform in this kind of patients. So quite interesting.
Thank you very much.
My pleasure.
Sorry, Alessandro, but something happened with the mic. I'm okay now.
Okay.
¿Quién más tiene deseos de hacer preguntas y aprovechar, pues, tener una respuesta directa del doctor Alessandro? ¿Nadie más?
If you want, you can also write your question to Raul, and then Raul, you can send them to me next days. If you agree and if you like that, I can give you my slides so you can study what I showed you according to your time and your possibility. No problem, it will be a great pleasure for me. But once again, if you want, next week or in September, we can have another webinar where we'll undergo to how to counteract some immune disorders and how to manage allergies.
Perfect, Alessandro. Thank you very much for your time, your knowledge, and your wisdom to be shared among us. I appreciate it. Muchas gracias a todos quienes han asistido a este webinar. Para Naturpharma, pues es un privilegio tener al doctor Alessandro y poder contar con su valioso tiempo y sobre todo el interés en aprender y en meterse un poquito más en profundidad con todos los temas de la medicina de Guna. Es realmente una gran satisfacción contar con este tipo de conferencias de alto nivel científico y pues espero que podamos hacer en septiembre una nueva charla. Muchas gracias a todos, que tengan un lindo fin de semana y pues nos veremos pronto. Muchas gracias a todos. Thank you very much, Alessandro. We'll see you. Have a good evening. It's almost midnight for you, so I hope you have a great weekend, Alessandro. Say hello for Bethany and ciao ciao.
I will. Ciao. Thank you. Good night. Buonanotte.
Muchas gracias.
Gracias a todos.
Muchas gracias. Muchas gracias.